Bismillahirrahmanirrahim. Quote of the day: a dream does not become a reality through magic. It takes sweat, determination, and hard work. Today, the topic of presentation is tobacco use and prevention program. I'm Dr. Rabbia Iqbal, PGR Community Medicine, and presenting under the supervision of Professor Dr. Saira Afzal, IPH Lahore. Learning objectives, introduction and global burden, types of tobacco product, epidemiology in Pakistan, pathophysiology and health effect, addiction and nicotine dependence, tobacco and non-communicable diseases, passive smoking and vulnerable group, economic and social impact, prevention strategies, cessation program and pharmacotherapy, and MCQs at the end. First of all is the introduction and the global burden. Global burden of the tobacco use: 1.3 billion current tobacco users worldwide, 8 million deaths per year according to WHO 2023, 1.2 million non-smoker deaths from the passive smoking, 80% user in low middle income countries. Key global facts include tobacco use in a single most preventable cause of the death globally, kill half of its users, one person every 4 to 5 years. If current trend continues, approximately 1 million deaths expected in 21st century. WHO declared tobacco use a global public health emergency. Economic cost greater than 1.4 trillion USD annually in health expenditure and lost productivity. Types of tobacco products, which include cigarette, which is the most common form, 6.5 trillion per year globally, filtered and unfiltered. Beads, which is the unfiltered form, hand rolls, common in South Asia, higher tar, carbon monoxide than cigarettes. Smokeless tobacco, chewing tobacco, snuff, gutka, pan with tobacco. It is a major cause of oral cancer. Hookah is shisha. Water pipe smoking 1 hour session is approximately equal to 100 to 1200 cigarettes. E-cigarettes and electronic nicotine delivery system, which is raising among the youth. Cigarette and cigar and pipes, higher nicotine per use used by the old males. It is also not safer than the cigarette. Next is the chemistry of tobacco smoke. Harmful components that are present in smoke include nicotine, which is highly addictive, alkaloid, carbon monoxide, produce oxygen carrying, tar, which is a carcinogenic, mixture of chemical, formaldehyde, benzene, arsenic, polonium 210, which is a radioactive element, 400 plus chemicals, 70 plus carcinogens are present in tobacco, nitrosamine, which is a specific tobacco specific, acrolein, and hydrocyanide. This is the phases of the smoke gas phase, which include carbon monoxide, nitric oxide, ammonia, cyanide, particulate phase, which include nicotine, tar, phenol, metal, mainstream smoke inhaled by the smoker directly, side scene smoker burned from the tip, which is a more toxic, third hand smoke is the residue on the surface and clothing. Next is the epidemiology in Pakistan. Tobacco epidemiology in Pakistan, 22.5% adult prevalence, according to STEP survey, 31.8 million adult tobacco user, 1200 per day youth initiation daily, approximately 1 lakh and 70,000 annual deaths, tobacco related deaths are occurring in Pakistan. Male prevalence is approximately 33%, female prevalence 5.8%. Smokeless tobacco, approximately 8.3 in adults, which include pan, chalia. Youth, 13 to 15 year, approximately 10% current tobacco use, according to Global Youth Tobacco Survey. Pakistan, urban areas greater than rural for cigarettes, whereas rural areas are greater for the smokeless tobaccos. Pakistan is the fifth largest tobacco producer in Pakistan. Tobacco industry contribute approximately 1.2 billion in tax annually. These are the risk factors for the tobacco initiation. Youth factors, which include peer pressure, social norm, early age at the first use, 13 year perceived social status, low academic achievement. Socioeconomic status, which include low income, education, unemployment, stress, exposure on to advertisement, affordability of product. Psychological factors include stress, depression, low self-esteem, mental health disorder, parental role modeling. Environmental factors include fear and family smoking, social acceptability, tobacco shop density, weak policy enforcement. Next, the health effects. Health effects of the tobacco use include respiratory effect, cardiovascular, oncological, and reproductive. Respiratory effects are chronic obstructive pulmonary disease, lung cancer, 85% attributable to smoking, asthma, chronic bronchitis. Cardiovascular effects include chronic heart disease, myocardial infarction, stroke, peripheral vascular disease, atherosclerosis, hypertension. Oncological include cancer of lung, larynx, and pharynx, oral cavity, esophagus, stomach, bladder carcinoma, kidney, cervix, and pancreas. Reproductive disorder includes erectile function in dysfunction in male, reduced fertility in female, preterm labor, low birth weight, sudden infant death syndrome risk. So this is the percentage of cancer causing attributable to the tobacco, which include pancreatic cancer, kidney cancer, bladder, oral cancer, esophageal, pharyngeal, laryngeal, and lung cancer. Lung cancer is greater than 80%. The carcinogenics that are involved are polycyclic aromatic hydrocarbons, cause DNA addict, nitrosamine, which is a potent lung carcinogenic, free radical cause of oxidative DNA damage, epigenetic changes occur, tumor suppressor gene mutation, KRAS mutation common in smoker lung adenocarcinoma. Next, is the passive smoking and vulnerable group. Passive smoking, the environmental tobacco smoke. The components are silent smoking, 2% more than nicotine mainstream, contain 400 plus chemicals, 50 carcinogen, ultra fine particle penetrate deep into the lungs. So classified as a class A carcinogen by the US. Health effect of the passive smoking. In adult, lung cancer increased 30%, chronic heart disease increased 20 to 30%. In children, carditis media, sudden infant death syndrome. Vulnerable group include pregnant women, in which result placental abruption, preterm labor, low birth weight, and in sudden infant death syndrome. Infant and children cause low respiratory infection, asthma, stunt lung growth, cognitive impairment. In elderly, accelerate COPD, cardiorespiratory decline. Health workers, occupational environmental tobacco smoke exposure is in unprotected setting. Next is the economic and the social burden of tobacco. 1.4 trillion dollar global annual economic loss from tobacco, 422 billion dollar global healthcare expenditure for tobacco. In Pakistan, 6.15 million tobacco-related losses among six average smoking-related hospitalization after every 6 weeks. Social dimension of tobacco use result financial harm, more income on tobacco, divert funds from the food, education, productivity loss, poverty cycle, child labor, tobacco farm use child labor extensively cause green tobacco sickness. Next is the prevention program and empower. WHO framework convention on tobacco control, first international public health treaty under the WHO adopted in 2003, in force 2005. In Pakistan, ratified in 2004. So the key prevention include Article 6, which is price and tax measure to reduce tobacco demand. Article 8, protection from the environmental tobacco smoke. Tobacco smoke-free policies. Article 11, packing and labeling, graphic health warning. Article 12, education, communication, and public awareness. Article 13, banning tobacco advertisement, promotion, and sponsorship. Article 14, tobacco cessation support measure. Next is the Empower Framework, WHO Tobacco Control Program, Tobacco Control Package 2008, which is monitor, track tobacco use, prevention policies, surveillance system, step survey, global youth tobacco survey, global adult tobacco survey, protect people from the tobacco smoke, 100% smoke-free laws in Pakistan in public places and workplace, offer help to quit tobacco use, cessation services, NRTs and pharmacotherapy warn about danger of the tobacco. Graphic health warning approximate increase 50% of the packaging. Enforce ban on tabs, which is advertising, promotion, sponsorship prohibition. Raise tax on tobacco. Tobacco tax most effective intervention. So next is the smoke-free places and legislation in Pakistan. Legislative framework include prohibition of smoking and protection of non-smoker health ordinance 2008. Prohibit smoking in public transport, educational institution, hospital, and office. Require no smoking sign in designated areas. Cigarette printing warning ordinance in 1979. Tobacco control cell, Ministry of Health, National the Punjab restriction on smoking regulation is 2024. Challenges and gap. Weak enforcement of the existing laws, high density of tobacco outlet near school, inadequate graphic health warning, tobacco industry interference in public policy, low tobacco tax relative to purchasing power, no comprehensive ban on all tabs, lack of national tobacco outline. Graphic health warning on packaging mandated under the Framework Convention Tobacco Control. Article 11 should cover greater than 50% of the packaging. Pakistan currently approximately 50% front and back under 2019. Plain packaging in Australia 2012 remove all branding, reduce appeal. Pictorial warning more effective than text alone, especially for the low literacy. So this is the tobacco taxation as a percentage of retail price, most cost-effective prevention tool. So in Pakistan is the greater than 40%, 10% price increase result 4% reduction in the consumption in adult. Greater elasticity in youth, 10% increase prices, 10% decrease in youth. WHO recommends tax greater than 75% of the retail price. In Pakistan, total tax 43%, which is below WHO threshold. Next is the cessation program and pharmacotherapy. Cessation include 5 A's and 5 R's. 5 A's are first of all, ask systematically identify all tobacco user, advise strongly urge all user to quit, assess willingness to make a quit attempt, assist, offer counseling, NRT, medication, arrange, schedule follow-up contact. 5 R's, which is the motivational interview for the unmotivated user. Relevance, make quitting personally relevant. Risk, acute chronic risk, reward, benefit of quitting. Roadblock, a barrier to quitting. Solution, repetition, repeat at every visit if not ready. Next is the pharmacotherapy for the tobacco cessation. First line agent include nicotine replacement therapy, which include pads, gum, lozenges, inhaler, nasal spray, double quit rate versus placebo, safe in CBD patients. So next is the varenicline, which is the most effective single agent. Side effect include nausea and vivid dreams. Next is Bipro. Pions SR, which is the dopamine and norepinephrine reuptake inhibitor. Community level tobacco prevention intervention, social school-based program, life skill training, DARE program, interactive smoke-free curriculum, teacher and parent engagement, community mobilization, community health workers, anti-tobacco social campaign, religious leader endorsement, Pakistan Tobacco Control Program, media and technology, anti-tobacco mass media campaign, M-Health, which include SMS to field sport, social media influence campaign, quit line and apps, workplace program, smoke-free place, policies, employment assistant program, subsides NRT for employees, incentive for successful quitters. Next is the National Tobacco Control Program, Pakistan, established under the Ministry of National Health Services, aim to reduce the tobacco use, legislation, awareness, and cessation. So surveillance is a step survey, global youth tobacco survey, global adult tobacco survey for monitoring tobacco use trend. Awareness, national anti-tobacco campaign on media, observing World No Tobacco Day on 31st May, research funding tobacco-related health research at a medical university. Legislation implementation of FCTC obligation, tobacco product regulation, integration of fit survey in primary healthcare, training of healthcare workers, coordination, interministerial coordination, finance, education, commerce ministries. Youth Tobacco Prevention Program. 90% of the adult smoker begin before age 18. Prevention must target youth. Global Youth Tobacco Survey, WHO CDC tool monitoring tobacco use in youth 13 to 15 and guide national policy. School-based life skill training reduce smoking initiation by 50 to 70%. Most evidence-based community resilience program monitoring sport, art program reduce boredom and peer pressure vulnerability. Digital literacy campaign, think before you puff. A social media campaign by the youth for youth. Minimum age law Pakistan mandate 18 year before, but enforcement extremely weak. Easy access near the school. Next is the e-cigarette and electronic nicotine delivery system. So key factor on electronic nicotine delivery system: heat but do not burn tobacco, aerosol not harmless vapor, contain nicotine, heavy metal, ultra fine particle. One port is equal to one pack of cigarette in nicotine content. Rising prevalence among teens. Ants use greater than 90% from 2011 to 2015 in USA, Pakistan. No specific electronic nicotine delivery system regulation as of 2004. WHO position regulate and there is strictly tobacco as tobacco. Next is the emerging crisis: e-cigarette, vaping product use associated lung injury. In 2019 USA outbreak, approximately 2,800 and 7 hospitalized and 68 deaths. Present as acute respiratory distress. Clinical feature include fever, cough, dyspnea, bilateral infiltrate on X-ray, diagnosis of clear no infection pathogen. Treatment includes steroids, supportive treatment, and cessation of vaping. Next is the smokeless tobacco, a neglected epidemic in Pakistan. Approximately 8.3% prevalence in Pakistan. 300 plus type of ST smokeless tobacco product globally. 50% cause oral cancer. 3.5 million smokeless tobacco cause death annually. Common form in Pakistan, Naswar, powder tobacco plus lime, oral nasal, extremely common in KPK and Fata. Gutka, mixture of arenica nut, tobacco, slack lime, cause oral submucosal fibrosis, pan tobacco, betel leaf tobacco, widespread across all provinces. Snuff, dry or most nasal or oral application. Next is the role of healthcare provider in tobacco control. Every clinical encounter in tobacco prevention opportunity. Physician seen every patient, document tobacco status and record, provide brief advice, prescribe pharmacotherapy, refer to physician clinic. Community health worker, door-to-door tobacco use screening, distributed IC material, motivate, quit attempt, refer to nearest health facility. Pharmacist, counsel on NRT use, identify drug interaction, dispense cessation medication. Dentist, direct oral ligand, detect oral ligand, early counseling, demonstrate oral cancer risk, visually refer to specialist. Next is the tobacco control and SDGs. SDGs target 3A strengthen implementation of FCTC as appropriate in all countries. SDG 1, no poverty, tobacco drive household into the poverty, free income for basic need. SDG 3, tobacco control central to reduce the NCD burden and premature death. SDG 4, quality education, tobacco money divert from the children education school program and prevent initiation. SDG 3, decent work, tobacco related illness, reduce productivity, cessation, improve workforce capacity. SDG 10, reduce inequality, tobacco burden in disproportionate in poor, taxation, reduce health inequality. SDG 17 Global Partnership. FCTC is a model of multilateral cooperation. WHO Civil Society Partnership. So, 31st May, according to WHO, is the World No Tobacco Day. So next we come to the MCQs. MCQs first, a community health officer want to reduce tobacco consumption quickly at the population level. Which intervention is considered the most effective? A. Open cessation clinic. B. Distribution educational pamphlet. C. Increase tobacco taxation. D. Organize health seminar. E. Training healthcare workers. So C is the right
B.
option. C is the right option. Increase tobacco taxation. MCQ number second, a smoker switch from cigarette to hookah, believing it is safer. Which health education message is most appropriate? A. Hookah contain no nicotine. B. Hookah smoke is filtered completely by the water. C. One hookah session equal to exposure to many cigarettes. D. Hookah does not cause cancer. E. Hookah is recommended by the WHO.
C.
Yes, C is the right option. MCQs number 3, a government ban all tobacco advertisement on television, social media, and billboard. Which AM power component is being strengthened? A. Raise. B. Monitor. C. Offer. D. Enforce. E. Protect. So D is the right option, enforcement. MCQ number 4, a patient who stopped smoking 6 months ago used nicotine gum and patch together, which is the main advantage of the combination of NRT. A, eliminate withdrawal permanently. B, superior effectiveness compared with single NRT. C, prevent all relapse. D, has no adverse effect. E, requires shorter treatment duration.
B.
Yes, B is the right option. MCQ number 5, a school introduced life skill training to reduce smoking initiation among students, which is the primary objective of this intervention. A, increase tobacco taxation. B, reduce nicotine content in cigarette. C, prevent tobacco initiation among youth. D, improve tobacco farming practice. E, promote e-cigarette use.
C.
Yes, C is the right option. MCQ number 6, which indicator is considered the gold standard for measuring the success of tobacco cessation program? A, number of counseling sessions conducted. B, number of NRT prescription issued. C, 1 year sustained rate. D, number of smoker registered. E, number of smoke-free zones established.
C.
Yes, C is the right option. MCQ number 7, a district health officer find that smoking prevalence among adolescents remain high despite awareness campaign. Which intervention is the most likely to reduce the youth smoking? A, lowering the cigarette prices. B, increasing tobacco outlet density. C, enforcing minimum age sale law. D, promoting flavored tobacco product. E, reducing school supervision.
C.
Yes,
C.
C is the right option. MCQ number 8, a pregnant woman is exposed to tobacco smoke at home because her husband smokes indoor. She later delivered a low birth weight infant. Which is this factor most common contributed? A, mainstream smoke exposure. B, passive smoking exposure. C, occupational exposure. D, genetic mutation. E, indoor air population.
B.
Yes, yes, B is the right option. MCQ number 9, a 52-year-old smoker with a history of myocardial infarction want to quit smoking. Which first line therapy is the most appropriate? A, cocaine replacement therapy. B, nicotine replacement therapy. C, amphetamine therapy. Alcohol substitution therapy. E, no treatment due to heart disease.
B.
Yes, B is the right option. MCQ number 10, a medical student want to estimate cumulative smoking exposure in a patient. Which measure is the most appropriate? A, body mass index. B, PGR. C, protein level. D, finger-stomp score. E, carbon monoxide level.
D.
So, B is the right option. So this is the answer key. This is the YouTube channel where the recording of this video will be uploaded. And thank you.
Assalamu alaikum.